Continuing this week on Out of the Fire podcast, this is part two of our conversation with Joshua Kelly of FlexPod.
Okay, so moving on, what are you excited about? What do you get up every day thinking about? Oh, wow, I'm going to solve this problem. And what are you really excited about now? You mentioned AI, and I've seen your work. You published some really cool stuff about evaluating LLMs.
There's a bunch of different things on the more narrow version of that question. I think pair-to-pair exchange is going to be a big thing, and it will be a big thing because it's not just another compliance interoperability effort. So finally, for the payer can really get value back. It's not just producing APIs for other people. We can act as a consumer. We're not just a producer here. We can act as a consumer. And why is that interesting or exciting? Well, the chart chase is this, massive problem. It's $1 billion problem. It can take 30 days to assemble and lots of manual human effort to assemble a chart when someone switches payers. So I think that that's something to be really excited about, both in the sense that in this smaller part of the industry, the subspace of the industry of health data and health interoperability, that's finally an excuse to do something for not just compliance reasons. And that appeals to different people in the business than just the compliance interoperability team. I'm with them, I'm on their side, but they're also under-resourced, right? They're sort of put in the basement, right? Like the weirdos, they need some computers or something, like the nerds in the basement, right? That's sort of how the teams get resourced and treated on some level. But if you then are talking to someone in member experience, right, which is not a cost center, it's a growth center for a healthcare payer, that and the onboarding, that's a whole other team with full other resourcing. And now they can care about an interoperability solution. So I think that's something to be really excited about. And it's longer term, but I think that's really cool. Otherwise, in the broader space, what I think there's sort of two things I think are really exciting and interesting. One is, of course, we published a set of FHIR evals. So we published a set of AI evals basically to do FHIR specific things. So how good are models at extracting data from FHIR resources? How good are models at generating FHIR resources from short text snippets? I think that there's a real opportunity in the short to medium term to create, with reinforcement learning, to create smaller private models that are better than the state of the art big foundation models that have lower latency, that are private, and that do really, really, really well at these small, narrow domain tasks. And if you don't believe me, there's lots of good research out there in public right now that suggests that domain specific, better than state of the art performance is possible with reinforcement learning, and specifically with reinforcement learning and verified rewards. And that's different than reinforcement learning with human feedback. It's newer. DeepSeek really pushed this into the public consciousness back in December and January, but all of that is now practically available to people. And in FHIR, we actually have something that could be used as a verified reward for the task of determining if we've successfully generated a bundle or resources to represent some healthcare event, and that is the FHIR validate operation. So I think that's really exciting because all of the pieces seem to be there for someone just to pick them up and put it together. And then the third, I think, is computer use. I think computer use seems like it's just about here, but it's not really. So people have speculated how computer use could be helpful in helping a healthcare org automate some of the administration tasks in particular. Again, there's sort of barbarians at the gates there, but computer use is still not yet good enough, I think, to be at a point where that's really happening in the wild, but it's going to. And I think that's something to be really excited about too.
I think the dreaded notepad example that you still see in every doctor's office when you come in, having you sign in. I mean, that's like crazy that it hasn't been automated. And a funny thing is I've given this example many times, but in one of my kids' doctor's offices for the pediatrician, they actually have kiosks that are supposed to be used, but they're 50% of the time they're out of order. So obviously,
I think the kiosks are dumb though, but so I think they're totally dumb. Whenever like it's like the self-checkout stuff. Like it can be really frustrating and annoying. And I think the kiosks are totally dumb. But I also think that the most underrated and underappreciated piece of healthcare tech is the smart health card and smart health links. And I think those could be really transformational and are also something to be really excited about. And it feels like the single most underappreciated, underutilized thing. And I don't know why. I think maybe half of that is just not stigma, but association of them to this like time in people's lives that really sucked, like to COVID era stuff, right? So because they have a genesis there with the vaccine cards and all this stuff, but they are so cool. And the ability to transport a resource in this permissioned or permissionless way, I think is really, really, really powerful. The example I like to use with people to sort of communicate that we don't use them enough is the lab result. So you can imagine going for a lab test and then literally getting your printed piece of paper. It's your receipt, and in the top corner, Smart Health link, QR code. And if you scan it right now, it doesn't go anywhere. Lab results aren't ready yet. Nothing's there. But if you scan it in the future or bring it to your doctor's office for your next visit, you don't have to worry that your doctor is not going to have the results. Because if for some reason they didn't get the copy from the lab or there was some mix up, you've got your piece of paper and you can give them that piece of paper. They can scan that Smart Health link. Maybe they ask you for the PIN. They might need your PIN. But that's the only thing that that's all the tech involved. And I just think that's such a cool workflow that is universally accessible that I can imagine the eldest people in my family using as much as I can the youngest. And I just think that there's something there. And the kiosk almost seems like this weird in-between period where we thought that like that was going to be the medium of exchange.
Yeah.
And I think that's like a great example.
Yeah, and it's like you can go to a gas station, you use your credit card on to get gas, which seems like that's a super, super like old-fashioned industry, right? Like, and that's a super old-fashioned, but somehow they've integrated smart cards on a gas station. And you would think like your doctor's office would have a much higher value from that, right? And like you could say, they're able to take the payments now, right? So every doctor's office has a credit card reader, but they don't have a health card reader, right? They don't have functionality enabled. And do you think that's part of the solution is to kind of look at the maybe financial industry and the fact that everybody has now an e-wallet, right? With your credit cards there in electronic form, and you can kind of transport your information. It can go on talking about the whole Plaid analogy. Basically, is that a good like blueprint for healthcare to follow? Is Plaid now works, have pretty much a third of the country that's using Plaid in some form or another. I can go on my American Express account and I can from there connect my other accounts like Chase and Citibank or whatever, and I can see everything in American Express, or I can use another service that I want, and it all works. How far away are we from that in healthcare, you think?
I think that all of the components. Well, first of all, one of the things I would say is that healthcare did learn from the financial services industry here. This launched in earnest in healthcare on top of OAuth, and that didn't happen in fintech, in the financial aggregator space. So that's a big difference. Is that from the get-go? Now there were people who were doing portal stuff before OAuth. Yeah, I do know the history, but very insignificant in the grand scheme of things. And I think that kind of step change to just using OAuth, I think that is basically a lesson that was learned from the financial side. There are still, and then I think from there are lessons that are hard to learn from financial services. So on the financial services side, ultimately, you only have so many accounts, right? Maybe you have a mortgage that's separate, and you have a daily banking account, and you might have a retirement account, 401k, maybe you have a trading account, maybe you have your Coinbase account. You have maybe 5 or 6, right? that's a lot. Maybe a handful of credit cards too, right? So you can build up to some number. If you're switching jobs every couple of years, or if you moved around, or if you start a family, or have any of these like big life events, you will just have healthcare data in a lot more places, just inevitably, in different locations. How your understanding as a person of those different components and how they represent, do they represent one company? Do they represent one healthcare network? Do they represent, is it the insurance company? Is it my doctor's office? So even like from the perspective of identifying correctly the data holder, who has my data? I think that's actually much more difficult than the parallel in the financial services world, because all of those accounts on the financial services world, you have a much stronger consumer association between the name of the entity and some actual like place where I go log in or I interact with it, or maybe I go visit in person. That's much weaker on the healthcare side, where, for example, we use this example a lot internally, the Blue Cross problem. So the Blue Cross problem is a problem that I think even people who work in healthcare don't understand, unless you are really in the weeds of the world of payers. You may not realize that Blue Cross is not one payer. It's a federation. And there are some states in particular, like I believe New York, where there are it's sliced into 3 separate regions, with Primera, Highmark, and I believe Avalanche has the third there. That's a mess of consumer associations and branding, right? So wait, I have Blue Cross, right? Well, what does that mean? Where is the data there? So I think that lastly, the more we can do to bring that data, I think there's been a big mistake historically in people's perspectives here in trying to create things like personal health record apps or personal health wallets, right? There's an audience for that stuff, but the audience for that stuff and the audience of healthcare interoperability developers is basically like, it's the same picture. It's the same group of people. And for sure, a handful of others, but it's niche. At the same time, though, I think we have to figure out a way to get the data into the hands of individual people, not because they're going to go look through it all or even understand it or care about it, but just because they are a natural transporter. They are a natural transport layer. And so the more that devices themselves, the more we can embed these things or put smart health links onto printed pieces of paper, the more that we can give people options, not to access it themselves for their own purposes, although that's great, but to give them the means to sort of solve the problem themselves. Almost like the problem of my doctor's office not having my lab results yet is a really, really common basic, like people get that and people take their own measures to solve that. They print out stuff, they bring folders, right? That's such a common experience. And I think there's an element there that we should try to solve. And it's probably some combination of different approaches, of the super low tech QR codes printed on paper, all the way to the digital identities that maybe people want to adopt or opt out of. Right. And I think there's just a lot more to be done.
I really like that idea you have of just like, sometimes you have to meet people where they're at. And sometimes it's like adding a digital solution on top of an existing paper process, like QR code or a link that people can scan, or when they go in, they point their phone and bring up the sign-in page. Those are the type of solutions that are going to make a difference. I feel like.
I really believe that we could have a large behemoth HIE approach could be outcompeted by a human sneaker net, like a patient sneaker net, where if patients just like, if it was just easy enough for people to transport really, really rich data, not because they care about that, they don't care about that. They care about their doctor having the lab results. They care about their doctor being able to see their health history, not the other stuff. They care about taking all that information and going asking ChatGPT, frankly, right?
Right.
Say what you will about it, right? About that from like a clinical perspective or whatever, but just from a real person.
But people are going to do that anyway. You got people that use it anyway. Like my example, I took my lab results from my kid's appointment and I put them into ChatGPT.
100%.
there was no integration in Epic that allows you to click a button to do that. I just copy and pasted it and put it in.
Yep.
And guess what? 99% of the people, that's what they're going to do. And guess what? I did get value out of that because I learned a whole bunch of stuff I didn't even know that my doctor didn't have time to explain to me. Or honestly, in the comments, they just said, oh, everything's fine. You're good. And then I actually got a whole explanation in a very easy to understand way from ChatGPT, you know? So like we got to figure out a way so that we can connect data to all these different use cases, right? And I think finally, I think there's a interesting conversation there.
Yeah, and Brendan really influenced me on the PHR. PHRs are like no one cares. I believe it, but he did convince me of that. That like the app for its own sake is a really niche thing. But that's I just think that and it's a tar pit idea. So classic like startup terminology. A tar pit idea is something that lots of other people have tried. People they get stuck in it.
You need I think that's the true promise of interoperability. People talk about interoperability as an end goal of itself. And I'm like, I always correct people. I'm like, interoperability is an enabler to get to the next step, which is insights and telling me how I can take care of my health better, my kids, whatever, and then tell me what I need to do to save money, to get a better health insurance plan, find a physician that's, able to give me an appointment without waiting for 3 months, all this stuff that right now people have, have to jump through hoops. So that's the enabling layer for that. But it goes both ways. It's not just, a patient. Its provider has to be in the loop. The system has to be in the loop. The payer has to be in the loop. So it's like this whole system. We're going to have, I think, a podcast episode where you, Brendan, and I know Fasten Health is another
Jason.
player in it. Jason can chat about where we're at on that time frame of enabling that true interoperability, and like the Plate in healthcare example, like you listed out some things that made me think from at least the CEO of Plate mentioned was the success factors and how they were able to overcome. I think it would be a really fun conversation, honestly.
Yeah, absolutely. Yeah, no, both I think very highly both of them. And Jason has done some really cool work recently with Tefka IAS, which is obviously a really exciting potential path. It's the high tech path. It's the path where we have national exchange. We have IAL2 credentials. I always have to sound that out. IAL2 credentials, where there's remote identity proofing, and you can do a network query for a person, and basically solve the problem of knowing where your data is in the first place, and then managing credentials is obviously a challenge. And there's some really good progress there recently.
Exciting. All right. Well, anything else you want to tell listeners about, or anything as a kind of final thought?
Maybe like a couple of other just somewhat random call outs on FHIR and the FHIR space and interoperability. We didn't meet, but first sort of saw each other on camera, at least at the SQL on FHIR working group call. I'm a really big believer in it. I think it's like number 2 on like my list of underutilized amazing pieces of health tech right now. So number 1, smart health cards, smart health links. Number 2, SQL on FHIR. Also following a very proud tradition of being terrible at naming things. Really, it doesn't have like much to do with SQL. Although they're starting to change that. They are introducing some ideas that are more SQL specific, but it's really just a really convenient way of tabularizing or tableizing FHIR data, which is normally very deeply nested. But really, we just want to look at something in a spreadsheet. That's been a really huge enabler for us in combination with bulk FHIR. So those 2 pieces of technology I just think are amazing. And then, otherwise published recently the FHIR evals. So definitely check that out if you're interested in having models, do FHIR specific tasks. I think that is something we're really proud of. And then, otherwise you can check out your own healthcare data, health insurance data at my.flexo.com. We publish a free application, and you can look at our payer coverage there. We also have a payer endpoint directory. So if you've ever wanted to go and look at all of the payer patient access APIs that exist, we publish that freely and openly. You can go to flexo.com/docs, and then there's a network tab in there that you can find a directory. So we put a lot of information out there in public in a way that historically people have sort of tried to keep private, and we'll continue to do that. But those are just a few things I'm kind of excited about, and I would point out if people want to check out more about what we're up to.
Yeah, and kudos to you for doing that. I know I've personally used those resources that you guys put out there. It's on my definitely favorites list, like within my top probably 5-10 links about what's going on in FHIR. See what FlexBot, published lately. And I think a lot of the developers in the space are really thankful to you, Josh, for doing that. I think having talked with like Darren and Graham and other folks in the FHIR community, there's really like not enough sharing of the implementation experience, and a lot of these type of resources are super, super helpful, because really like every company doesn't have to reinvent the wheel, right? Like you guys figured something out, publish it, just share what you have. It doesn't have to be secret sauce, but like just make it easier for others to do, like what Josh and team did here. All right, well, thanks for joining. This has been a really awesome conversation, really fun.
Yeah, thanks for having me on.
All right. Thanks a lot. And if you like this podcast, please go ahead and subscribe and like. We are now on Apple Podcasts, Spotify, YouTube, whichever other services, obviously Substack as well. And I have a channel on Substack, so subscribe to that as well. Thank you, Josh.